It's an exciting time, as we all know, with these meetings. The proliferation of technology in the glaucoma space, especially the minimally invasive or micro-invasive space, is continuing. I think we got excited from many years ago with the iStent and a few other stents that came out. Now we're seeing more and more devices, more and more procedures that are coming out, and so I think we're still challenging ourselves to do better than what we started with as well. And so I think we saw a device today in presentations that really focused a lot on the balance of mechanism of action, understanding how do we achieve better outflow, whether it's through the conventional pathway or bypassing it. But we also saw the importance of also safety. And I think what we're seeing now is more and more of these devices coming out. They're trying to manage the challenge of trying to really reduce the pressure low enough to reduce the drop burden that we need. At the same time, how do we manage the safety part of it? So some of the new devices, some of the bypass devices that are more efficient, I think less invasive than even prior, I think have really helped kind of advance the field in terms of our ability to offer earlier intervention now. And also even the conventional pathway, better ways or at least a different understanding of how to maximize outflow through the conventional pathway, still maintaining high safety, but trying to get that golden ticket of reducing the IOP and the drop burden. So I think we're seeing multiple levels, multiple platforms to achieve those two balances. What's important for glaucoma, again, is long-term data. I still think we'd see more long-term data, and really just like we've seen with the Horizon trial with the Hydrus stent that showed us after 3 years, 85% less chance of needing further incisional surgery in the group that had the Hydrus and cataract versus cataract alone. I think more of those type of outcome analyses are important because that will allow us to truly justify, okay, not just bringing the pressure down is important, but bringing the pressure down and dealing with compliance issues is translating to less progression or less need for incisional surgery. I think we need more of that. I think we need more understanding of outflow. What we don't have right now is a good preoperative assessment of where is the resistance to outflow preoperatively. So when I'm at the chair with my patient and look at the patient, I don't know is the resistance at the TM, the Schlemm's canal, the distal channels. So we're using surrogates. Do they do well with SLT? How many drops they're on? These surrogates are telling us, okay, maybe where the resistance might be. So then we perform a surgery that we think might work, depending on where you think the resistance is. And so I think what's going to happen, I think what's going to help us a great deal, is the ability to understand preoperatively where the resistance is, to better understand outflow and why certain patients have a decreased outflow system that will help us determine which device may work for each patient. Until then, it's still, okay, how am I surgically? Do I feel comfortable? Is it safe? And does it have the efficacy I need? And that's kind of a balance. I think that's why you're seeing so many different devices working on different parts of the outflow system. But the main focus in all these devices we heard today was maintaining high safety. You saw that safety. Adverse event profiles are extremely, extremely good, whether it's the conventional pathway or like an ELT procedure, whether it's like Sanoculis, the company there, performing a kind of anatomy where you actually have a bleb still, but in a very controlled, safe bleb with really safe outcomes. Or we have the Belkin laser, which is an SLT laser from a transscleral. All these devices and procedures are maintaining high safety, giving us an excuse and a rationale, rather, for earlier intervention and not relying on patients' progression, obvious progression, before we consider reduction of pressure without having to take drops all the time.